Let's continue our talk on the kidney stones. In this video we'll talk about the remaining kidney stones. The uric acid stone, it is caused by the elevated serum uric acid. Now this could be seen in leukemias secondary to tumor lysis syndrome, gout, which is the most common one, and the Lesch-Nyhan syndrome can also lead to the uric acid stones. Now, this is never complicated, and we do not give thiazides here. Thiazides was the choice when we talk about the calcium oxalate stones, but here thiazides are not, because the thiazide can cause hyperuricemia, and we don't want that, because it is already, if we have high uric acid in the urine, the chances of uric acid stone will increase. The urinalysis will show acidic pH usually less than 5.5. So it is acidic pH. So the application of this point is, for the treating, you can do alkalization, as we talked earlier in the first video. Alkalization of the urine could be one of the treatment. The stones are not visible on the X-rays. Now that's because they are the radiolucent stones. The treatment with allopurinol, which decreases the production of uric acid by inhibiting xanthine oxidase. The another drug which can also do this is febuxostat. Febuxostat is more newer drug compared to allopurinol, but these both the drugs can decrease the production of uric acid by inhibiting xanthine oxidase and could treat the uric acid stones. Now we have to take a good care when treating gout. So the first line treatment for chronic gout is xanthine oxidase inhibitors, like we talk about the allopurinol and febuxostat. They are preferred over uricose-uric drugs, meaning uricose-uric drug they increases the urinary excretion of the uric acid, and the drugs that are probenecid and sulfenpyrazone, they are the agents which increases excretion of the uric acid via the urine, and that's why there will be increased chance of uric acid stones if we treat the gout by those two drugs, which were uricose-uric drugs. Now this was one point. The second point is, like, probenecid and sulfenpyrazone inhibit organic anion transporters, OAT, organic anion transporters, which normally functions to absorb the uric acid. So uric acid gets absorbed because of these transporters, and this is getting inhibited by the uricose-uric drugs that is used to treat the gout. So that's why this the drugs that are the probenecid and sulfenpyrazone are not used, because of these two reasons. Now a weird fact about probenecid. Now this is a very weird fact, and the probenecid helps to maintain the serum beta-lactam levels. There can be a question somewhere asking about a patient on beta-lactam and probenecid. So you don't have to confuse that this patient have gout, this patient have no gouts, but still he is on probenecid. And the question would be why? Because it will decrease the renal excretion of beta-lactam. So probenecid inhibits the excretion of beta-lactams. So it will boost the beta-lactams metabolism, and it will act more. So not always uric acid patient, not always if patient has no uric acid, probenecid is given, and that's a weird fact about it. Let's talk about the stone, the cystine stone. It is a rare, and cystine is formed by putting two cystines together, And cystine stone is usually hexagonal in shape and can occur in young adult due to an inability to reabsorb the cola. And that is the dibasic amino acid which has cystine, which has ornithine, which has lysine, and which has arginine. And this is all what we talk about was the autosomal disorder, the inherited defective problem that we talked about in the first video when we talked about the overviews of the kidney stones. So it is a congenital defect in reabsorption of amino acid cystine from the urine, and urinalysis will be the acidic urine, pH less than 5.5, and not visualized on KUB because it is a radiolucent. And as it is forming in acidic urine, alkalization would be one of the treating factor. Now let's talk about the other miscellaneous stones, which is the main thing is the crystal nephropathy. Now where does this crystals come from? Let's suppose patient has HSV or the shingles. Now here we treat the patient by acyclovir, and acyclovir can crystallizes the urine, and these crystals can cause crystal neuropathy and cause the renal issues. And the other one, if let's suppose patient has HIV and he or she has been treated for indinavir, and indinavir again crystallizes the urine and can form crystal nephropathy, damages kidney. These are very rare, but it's a good to add to complete the kidney stones. Stay tuned for the third part, which will talk about the investigation in detail and the management. Thank you.